Hello. Good afternoon. I'm not here to recruit you, so you're fine, you can relax. I did used to work for Scouts, and I used to work for them before then when they were too shy of the ambulance service. So I have worked in the ambulance service as a technician, paramedic and an ECP. At the moment I'm in higher education and I'm the senior clinical research fellow for paramedics at the University of Hertfordshire. But I always like to come out and talk to paramedics, so I'll just talk to you for about 20 minutes or half an hour or so about toxicology and hypothermia. I don't know how much you know about toxicology, poisonings, quite a broad area. I'm just going to have a look at one particular part of it. So I'm going to stand here because apparently I'm being filmed, which, okay, that sort of goes with it. So you can listen to this if you can't sleep later, and it might help you fall asleep. So this is the London Ambulance Service here. You've probably had a chat with them already. I did a quick, very short case series study. One of these guys here with the red epaulets there is one of their specialist paramedics, very highly skilled group, very small cohort. Good to work with, and I hope to be doing a bit more work with them in the future. But I wanted to talk to you just before we get on a bit about body temperature. So unfortunately, this is not always the best thing to have straight after lunch or in mid-afternoon. But we are going to talk about, or I am going to talk about hypothermia and hyperpyrexia. And there is a difference between the two. Now, your body temperature is somewhere around 98.6, that's about 37 degrees centigrade. It varies a bit, it goes up. It's about highest actually about now. By about 4 o'clock you'll be about the warmest that you're going to be. And you sort of get a bit cooler through the night and towards the morning. And your body temperature is very, very tightly regulated, very, very tightly regulated by an area in your brain called the hypothalamus. It's a very tiny thing. It's about actually the size of about the end of your little finger there, but it actually regulates just about every cell in your body. This has this area called the hypothalamus has what we call heat and cold sensitive neurons. So if you were to decide to take all your clothes off and run outside, very quickly you'd get cold, and your hypothalamus would recognise this, and you'd start to show all the outward signs. So you'd start to shiver, and you'd get goosebumps, and that sort of thing. And of course, if you were to put on a load of clothes in here now, you'd very quickly get warm, and you'd start to show signs of being overheated. You'd become quite flushed and dilated, and you'd start taking clothes off. And that sort of thing. The spinal cord itself is thermosensitive, so if you cool down your spinal cord, it does recognise, so it will actually activate your hypothalamus. If you pour a load of cold water into your stomach, that will then activate your hypothalamus as well. So it's quite an intricate system to keep your body temperature within these very tight homeostatic limits. And you also have in your skin what we call cutaneous thermoreceptors, so they act very, very quickly, part of your nervous system. They don't wait for your blood to get cold. They actually activate very, very quickly. Otherwise, you wait for your blood to get to sort of 33 degrees, you'd be heading close to death, really. So they act very, very rapidly and start sending signals to your hypothalamus and telling it to warm your body up or cool it down, depending if you're too hot or too cold. So I'm sure you've all been hot, cold, you all know the kind of behaviours that you kind of exhibit when you're in either of those situations. Now, at the top is fever, or what we call pyrexia. Are you kind of familiar with these? Probably broadly familiar with these terms. Yeah, fever or pyrexia. Okay, and then below that I put hypothermia. Okay, so there is a distinction between the two, and the way we manage and treat them is actually different as well. Fever itself, as I put here, is an elevation of body temperature above normal variation, which occurs as a result of an alteration in your hypothalamic set point. So if you could think of your hypothalamus as like the thermostat on your home, like that, what happens is this gets turned up slightly, and the blood that bathes the hypothalamus thinks you're cold. It thinks it's cold, so it tries to heat that blood up by getting you to shiver. And probably when you've met people in the early stages of fever, they get, have you seen them, they get sort of double over like this, and they shiver like this, and they look very pale. And what your body is doing is it's constricting all your blood vessels, getting blood towards the core of your body, keeping it there, keeping it warm. And of course, you then know when somebody's, you used to talk about fever breaking, when your fever breaks, you then sort of overheat and you want to go, oh, take all your sort of bedclothes off and lay there and think, oh, I feel a whole lot better. Now, these are caused by something called endogenous pyrogens, or EPs, okay, and these are released when you have infections, particularly when you've got white blood cells, macrophages, what we call big eaters. When they're highly active, when they're fighting infections, they release these endogenous pyrogens and they go to your hypothalamus and they reset this set point, okay? They reset it and get your body to heat up. The reason they do that is, does anybody know why they do that? Why you heat your body up? Excellent, they certainly do, yeah. So phagocytic activity, so the activity of white blood cells is very, very highly increased when your body is at a higher temperature. Also, a lot of the organisms that do you damage by viruses and bacteria, they optimise to work at body temperature, so around 37 degrees or so. If you can heat your body up, it makes the environment quite hostile for them. They can't function as well. Fever is actually a very important defensive mechanism for our body. We often get quite fever phobic. As soon as somebody gets a temperature, we think, oh, perhaps we should give them some antipyrexia or some paracetamol or something like that. But these endogenous pyrogens, they get into the vasculature of your hypothalamus and they cause the release of something called prostaglandins. Okay, and that's what resets your hypothalamus. Okay, and this explains the activity of ibuprofen, paracetamol, and the corticosteroids all work on those systems and are able to bring your temperature back down. Now, hypothermia, on the other hand, is a state of body's heat production exceeds your body's capacity to dissipate it. So the production of heat is greater than your body can dissipate it. Most common form that you'll see is probably heat stroke, often seen in marathons and outside sporting activities. But lots or some are caused by what we call xenobiotics, drugs, fancy way of saying it, both licit and illicit drugs. And what these can do is constrict your blood vessels, things like cocaine, amphetamines, constrict your blood vessels and raise your body's metabolic rate. So all the things that make people feel good when they take them, cocaine, amphetamines, that sort of thing, they are also all the things that cause your body to generate lots and lots of heat. And what you get is this kind of increased muscle activity, and I've put here eventually seizures, rigidity. And we're starting to get a bit more of a handle on this. Anybody heard of the serotonin syndrome? Yeah. Yes, you have. Have you actually seen it?
No, it's really bad.
Okay. Probably worth you all having a read as aspiring paramedics, have a read about the serotonin syndrome. A bit more common than we actually think it is. And neuroleptic malignant syndrome, that's quite rare, seen in patients taking neuroleptic drugs, essentially for schizophrenia. So here's a kind of, the one in the middle is obviously hypothermia, so your body heat there has been detected as too low, and heat gain is needed, so you can see the blue bar there, it's needed to be brought up into line with the green bar, which is normal. And then on the far, on your right-hand side, you can see hyperpyrexia, so fever. So there's your hypothalamus has now been set at a bit higher, and you can see the blue bar there. That needs to gain heat, and your body will do that by generating muscular activity, shivering, those sorts of things. Now, in hypothermia, which is on your left-hand side, you can see that what we've got is this high temperature, and what is needed is heat loss. But the heat loss is not enough, so your body will continue to get hotter and hotter and hotter. Why is this important? Because if you get to about 41 degrees, it's fatal in about 85% of cases. So anything over 41 degrees is fatal about 8 in 10 cases. So just to tell you again a little bit about the pathogenesis of fever. This here, as you can see on the left-hand side, is these infections, often autoimmune conditions as well. Also, head trauma can do this. And here's the activity of your macrophages and endothelial cells. And here's your EPs that I talked about just earlier, your endogenous pyrogens. Okay, there's things like interleukin-1, 6, TNF, doesn't matter. You know them, they're just quite interesting if you see them in your textbooks. And as I said before, they get into this area here. This is the blood vessels around your hypothalamus, particularly the front of your hypothalamus. And they start this cascade of arachidonic acid. Here's your prostaglandins, and then here's the elevation of the hypothalamic set point. And it's at that point where then you'll start to see this heat production. This is what mothers recognise in their children all the time. They start to see this outward behaviour that tells them the child's probably feverish. Not just children, but certainly very easy to recognise in them. And of course, this is fever, and this is hyperpyrexia or pyrexia. And paracetamol and ibuprofen and corticosteroids, they all work in this area here around arachidonic acid and prostaglandins. They lower them down, they reduce the levels of prostaglandins, and so the elevated set point is brought back to normal. Okay, so that's how they work. This is, it's an ATP synthase actually, the big red blob in the middle. Excuse me, it's in all of your mitochondria. And what you can see is it's used to generate ATP. Is anybody really familiar with this? Okay, I'll give you a brief sort of whistle-stop tour. So this is an ATP synthase here, okay, and it's driven by protons. You see them there, those hydrogen ions at the top. And what they do is as they rush through here, they're very, very high speed, very highly charged molecule, and there's a high quantity on the outside here, a very small quantity on the inside, and they rush through this sort of red blob here, if you like, and as they go through, it spins like this. It is like a mechanical pump, very microscopically small. You can see them on YouTube, fascinating little microscopic view of one. But as these protons, these hydrogen, as they rush through, this thing spins like this, round, 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 and there you've got ADP and phosphate, and it's joined together to make ATP. Okay, and your body uses lots and lots of ATP. If you were unsure, your body actually generates its own body weight in ATP every day. So your body generates its own weight in ATP every day. So you're about 60 kilos, which is about 60 kilos of ATP every day. It's vital to all of the functions of your body. Okay, you won't last particularly long without it. And what happens in what we're seeing a lot of hypothermia, drug-induced hypothermia. I put this one up here. This is quite a new phenomena. It's an old one. It's not really a drug. It's actually it's something they used to use to make munitions back in the First World War. But this is 2,4-dinitrophenol, or DNP. You can buy it off the internet. It's not legal, but you can buy it off the internet. Lots of this stuff comes off the internet. It's a weight loss product. Okay, I wouldn't advise you use it, but it's a very, very effective weight loss product. And what this does is it actually passes through your membrane here, your mitochondria, and it collapses this gradient of protons here. So instead of producing ATP, your body starts to produce heat. And as it produces heat, it starts to induce weight loss. Okay? Unfortunately, you're not producing ATP, which is important, and you're getting your body up to, or can get up to, quite dangerous temperatures. There's been a bit of a spike in about half a dozen people killed with this particular drug. It sounds like very small amounts, but it is still worth mentioning. And people buy this off the internet. It's been banned for years. It's been banned by the FDA, and it's been banned over here as a weight loss agent. But people, you can log on anywhere now and buy this stuff from China or down the Silk Road. Also, aspirin does a very similar thing in overdose. So aspirin, if you ever see aspirin overdose, that also collapses this proton gradient as well and causes heat production. Okay, and again, if we get to about 41 degrees, you'll probably you'll do very well to survive. Certainly, you'll have some sort of neurological disability. Now, within all of this, there's a group of proteins called uncoupling proteins, or UCPs, which we're becoming quite interested in. I'll come back to those in a moment. Why is this high temperature so important? Well, they speed up metabolism. So the hotter you are, the higher your metabolism. Okay, and what you can see here is this is enzyme activity, and you can see it's got a bit of a sweet spot. Okay, so anything between about 30 and 40, all of your enzymic activity is pretty good, working as it should be. Lots and lots of them needed to produce ATP from glucose. And then you can see at about 40 degrees there, this line, this activity starts to take a rather serious drop off a cliff. Okay, so your enzymic activity is not particularly good, and then you start to, very, very important to drive things like your respiratory and cardiovascular centres. And what this eventually leads to is the kind of arrhythmias that you'll be more familiar with than I am. Okay, and this here is these uncouplers that I talked about. They also are like a protein channel that goes through the mitochondria. So again, they collapse this proton gradient and cause heat production. So they switch from ATP production to heat generation. Has anybody heard of this one? This is green Rolex at the top. Anybody heard of this one? It's a type of ecstasy. I was talking to a colleague of mine in Scotland where they had a crew went out to a guy. They thought he was actually dead. They thought he was in rigor mortis. He wasn't. When they put their hand on him, he was absolutely red hot. They thought he was still alive. But they couldn't do anything with his airway. He was completely twisted. He couldn't get his airway open at all. And he'd taken this particular drug here. There's been about 20 deaths, 25 deaths from this particular type of ecstasy. And it caused this profound muscle rigidity. So again, these guys were really rigid, like this, couldn't open the mouth, Tris was very, very hot. And of course, what's happening is they're burning huge amounts of ATP, their muscles are in complete tonic contraction for the whole time, their metabolism is high, their enzyme activity is very low, and the amount of ATP dwindles very, very quickly, and of course they end up with a metabolic acidosis and ultimately death. The one at the bottom with the kind of S on it, this is the Superman ecstasy. This has been seen more recently in East Anglia, and this killed 5 people in a weekend. Okay, so, or by the same mechanism. Ecstasy, as you might have heard it, as 3,4-methylenedioxymethamphetamine. So it's a type of amphetamine. Both these here cause a number of deaths. Very good. So these have caused a number of deaths, and the problem is that they tend to appear in clusters, so we get outbreaks of these particular deaths. They're very difficult to predict by epidemiology. We get these big sort of outbreak clusters, a very, very high mortality with these patients, very difficult to stop. And so if we look at some of the reasons why, what's called the toxidrome, if you're interested, the toxidrome, or what's called the toxic syndrome, you short it to toxidrome. What is causing this? We're not entirely sure. We think ecstasy, we know, causes a huge release of serotonin. Where's serotonin? You see people who take, yeah, you've got a happy neurotransmitter, if you like, so why people take SSRIs for depression. Or maybe something to do with monoamine oxidase inhibition, or stimulation of your sympathetic nervous system. So we're a bit unsure. What is this mechanism here of hypothermia? Is it increased motor signaling to your muscles? Again, we're not entirely sure. Uncoupling proteins, more on those in a minute. We think this probably holds the key to solving the problem. And is it something to do with alpha-1 and beta-3 receptors? These alpha-1s are in your blood vessels. They cause profound vasoconstriction, so they prevent heat dissipation. Or possibly these beta-3s here, which are uncoupling your oxidative phosphorylation, reducing ATP production, increasing heat production. So clearly it's not appropriate for us to experiment on human beings. We can't randomise half of you to ecstasy and half not and see if you get hot. So we use rats. It says mice here, but it's actually rats. This is a study done on rats. The blue bars here, these are rats who've been given equivalent dosing of 10, 20 and 40 milligrams of ecstasy. And so clearly it made them feel good just momentarily. And on this side here, these are rats specifically bred to lack these uncoupling proteins. So what you notice very, very quickly, this is almost immediately, These are the spikes in temperatures. Okay, you can see they've gone up by nearly 2 degrees centigrade after being given ecstasy. This was about 20 minutes. If you look at these bars here, you give similar doses to rats, I should say, that have been bred to lack the uncoupling proteins, so they don't have the genes that produce these uncoupling proteins. See, there's very, very tiny or almost no rise at all in temperature. These are temperatures taken 2 hours later. Okay, and clearly those who've had the biggest dose are still exhibiting quite a high spike in temperature. Why is this interesting? Well, if you can't sleep at night like I can't, then it probably is quite interesting. But this here is the mortality, the survival rate, I should say. So those mice bred without the uncoupling proteins, 100% survival. So none of them died. Okay, or rats. So I keep saying mice because it's written here, they're actually rats. Okay, this here is 20 milligrams a kilo, so about 80% survival rate, and this is 40 milligrams a kilo here, so about. So you can see there's a definitive drop in survival dependent on the dose and these uncoupling proteins. One of the most important aspects of this hypermetabolic state that's going on is that your muscles are profoundly contracted. They're in this state of almost tonicity the whole time. And as they spend time in this state, they start to break down. Okay? And as they break down, they release things into your bloodstream, things like potassium, creatinine. Okay? And none of these things are particularly useful to you in high doses. So you start to release breakdown products very, very quickly. And these products go to your kidneys. And when they get there, they cause something called rhabdomyolysis. Now, I always suggest that every paramedic should know what rhabdomyolysis is, because there are lots and lots of causes. Okay, so my suggestion to you is go away and have a look at that. But on that very thing here, again, these are rats who've been, we can't obviously use human beings and randomise them to these studies, wouldn't be ethical. So, these are rats, again, who've been given 40 milligrams per kilo of ecstasy or MDMA. You see the big spike in temperature very, very quickly there, from 37 to 41 degrees. Okay, very, very quick. Okay, these rats here have been treated with an alpha blocker, one called prazosin. You might see it on some of your drugs list. And these ones here have been treated with an alpha blocker and a beta blocker at the same time. And you can see there, they exhibit almost no rise in temperature whatsoever. Is that okay with everybody? Is that reasonably familiar? I'm a pretty busy slide, I understand that. So, no protection at all, big spike in temperature, starts to wane off, alpha blockers and beta blockers. So, no rise in temperature at all. Don't worry about seeing D. B is probably the one we're interested in. B is creatine kinase. It's a breakdown product of muscle hypermetabolism. And can you see the group here with the big spike in temperature? Massive spike in creatine kinase. Okay, this is too much really for your kidneys to deal with. And so what happens is these products block your nephrons, very small functional parts of your kidneys. They block them, and you develop what's called ARF, or acute renal failure. Okay, and this is what ultimately is the pathway to death. This is why it's so dangerous. Once you get to about 40 degrees, we've got 41 degrees here, anything over that, you can see these big spikes here, and it's fatal almost all of the time. So you die from hypermetabolism, overheating, and rhabdomyolysis causing acute renal failure. This is myself, there I am, and a good friend of mine, and friend and colleague of Matt as well, called Tim Edwards. He's a consultant paramedic at the London Ambulance Service. We looked at hospital cardiac arrest, complicated by pyrexia. So a very short case series, I won't dwell on it too much, and here they are. These are 6 individual cases attended by specialist paramedics. I think what's interesting in all of this to take away is case number 2 and case number 4. These are both incidents at clubs. I think a club called Fabric in the centre of London. If you work there, I think you're probably more familiar with it than I am. So a couple of people here who've taken, we think, amphetamine-based drugs, ecstasy. What's distinct from these two is the others are what we call hyperpyrexia. So we've got clearly some sort of infectious process here. But these two are probably not. These are probably hypothermic cases. And what you notice is, can we all see the temperatures here? Can we see those? Much, much higher than all the others, 42 degrees and 41.6 degrees there. Very, very hot. Whereas if you actually look at those with pyrexia, 38.3, 37.7, 37.9. So they don't get to those hyperpyrexia very rarely achieves these same levels of heat production. And as you can see, in accordance with known data, this patient was pronounced life extinct at the AED, and again here pronounced life extinct at the ED, whereas these three here achieved ROSC. I don't have the follow-up data as to whether they actually survived to 28-day or 90-day survival. But as you can see here, these are both drug-induced. Can you see that? Both had trismus as well. We're all familiar with it. All had virtually unmanageable airways. I think one of these ended up having a cricothyroidotomy, which is at sea, which is something their specialist paramedics do. Unfortunately, it wasn't successful in saving the patient. And just I thought I'd mention as I'm finishing, this is neuroleptic malignant syndrome. That's House. Sorry, the slide's a bit poor because it's a bit light in here. Neuroleptic malignant syndrome presents again in a very similar way. It's essentially schizophrenic patients taking things like prochlorperazine, which I struggle to say, haloperidol, those kind of drugs. Anything from about 0.02 to 3% of patients taking these drugs. Unfortunately, there's a high mortality. Somewhere about 1 in 5 patients will die from this if they develop it. And again, you can see it in very recent or rapid dose escalation. So this is your kind of history taking, switching medications or very high therapeutic dosing of neuroleptic medications, haloperidol, as I say, prochlorperazine, thiopentol, things like that. And again, this causes hypothermia, rigidity, altered mental status, and very autonomic instability. So pulse tends to go up and down, as does the blood pressure. They also develop something called lead pipe rigidity. Anyone know what that is? Their arms become very, very rigid like this. If you push their arms, they develop this almost stiff look to them because there's an excess of dopamine in their central nervous system. And again, tremors, hypothermia again, and tachycardia and unstable blood pressure. The thing about both of these cases is that if you learn nothing else today, I hope you have, is there's no role for paracetamol in hypothermia. Okay, there's no role for paracetamol in hypothermia. There is a role for paracetamol and antipyrexics in hyperpyrexia. Okay, fever caused by endogenous pyrogens, the things I described at the beginning. There's no role for paracetamol in neuroleptic malignant syndrome, and there's no role for paracetamol in hypothermia caused by things like amphetamines and other drugs. What these people need is generally very, very rapid cooling. If you can get their temperature down very quickly, the chances of them surviving are high. If you've got ice packs to hand, very, very good. Okay, strip them off, get ice packs, armpits, in the groin, get the temperature down if you can, okay, by whatever means you have at your disposal. Establish a fluid line. These people generally need fairly large volume resus as well, and it'll help keep their kidneys active, so it'll help maintain a urine output as well. Obviously, good airway management and oxygenation is also important. If you're good at these supportive measures, you can generally improve these patients' chances of survival. But as I've said here, you'll need someone who can give you something that I can't. So unfortunately, we don't carry the drugs yet. And that's the kind of thing that I'll be working on, hopefully for my PhD, as to what sort of drugs we need out there to combat this. But at the moment, you don't have them. The drugs are things like dantrolene, bromocriptine, and some of the alpha and beta blockers. So at the moment, we don't carry them, but obviously there's always room for a bit of research in that. So hopefully I've got across to you the difference between hyperpyrexia and hypothermia. Would that be fair? Where the role for paracetamol is and where the role for paracetamol isn't. And remember, just think about your history, where you're actually meeting these patients. Is it in a nightclub or something like that, an event? Possibility there that they might be suffering from hypothermia. So what they need is cooling, fluids, good airway management and oxygenation, good supportive techniques, and then getting them into hospital. Thanks very much, and there's some references for you. Thank you.
Great. Any questions for John whilst he's here?
The deaths you described from the pills earlier, they weren't, I remember reading about it, they weren't MDMA, they were classed as other drugs, masters MDMA.
Yeah, well, some of them were PMDMA, which is some were PMDMA, paramethylene deoxymethamphetamine. Yeah, good point. They're all part of the amphetamine class, but yeah, PMDA is much more toxic than MDMA, and that's why these people. Well, and it's also metabolised much slower, so they weren't getting the benefits, so they were taking another, and then of course they got a huge dose from it, and that's what caused them to overheat very quickly. But yes, you're quite right. Yeah. But do you think you could tell the difference by looking? Does anybody think they could tell the difference if you bought them in it? Yeah, they present the same. I know a lot of nightclubs now are developing some fairly sophisticated testing mechanisms, and they kind of put things out on Twitter very quickly and say, don't take this if you see this or see that. But at the moment, it's very difficult.
Just regarding that, because it's hard to determine which one's which, you said one of them impacts the kidneys. If you give them fluids, surely they're going to do more harm than good.
No, if you can keep the kidneys, if you can keep a urine output, you'll do more good than harm. Even if they're kidney, you probably won't get, not in the stage that you get to them. If you get them to that stage, they're probably about to arrest. You'll get to them much earlier than that. Okay, you'll get to them probably at the collapse stage. I haven't looked at this kind of data. You'll be getting to them in the collapse stage, okay, and getting them cool and getting fluids running is your priority. But no, certainly even when they're reaching that end stage of acute renal failure, perfusing the kidneys and getting urine output is still very important. Yeah, I think so. Thanks very much for your time. Thank you.